Good afternoon, everyone. This is welcome to the National Native Health Research Training Initiative webinar. This is the last of 7 webinars that we will have hosted. We're grateful that you were able to join us today. My name is Rachael Tracy. I'll be the moderator. I work for the Indian Health Service. We're first going to go ahead and get started with some logistical information, and then we'll move into a blessing to start us off. Maggie?
All right, hi, I'm Maggie. I work with AHEC, the American Indian Higher Education Consortium. We just wanted to go over a few things before we really get into our webinar. Please make sure you should be automatically muted when you enter, but please just make sure that you are muted. Mute your phones, computers, and microphones. We will have a question and answer session after each presenter. Feel free to type your questions into the chat box to share them with us, and we will pull from the chat box those questions. You can also, if you're on your phone, for instance, you can email them to me at mgrandon, MGRANDON @AIHEC.org. Finally, we will do an evaluation, real brief evaluation after each presentation. So if you're on your computer, please look for that, and we hope that you will take just a minute to complete that. And if not, if you're on your cell phone or if you're viewing this after the live presentation, we will have an evaluation available online. For your information, we are recording this webinar, and it will be posted online along with all of the presentation material. And that is it. I hope you enjoyed today's webinar.
Thank you, Maggie. We are going to go ahead and get started here, and I would like to introduce a very special guest here who is going to lead us in a prayer to help us get started in a good way with our webinar today. I'd like to introduce Professor Dennis White. Professor White holds a BA and an MA in mathematics from the University of Wisconsin system. He received his BA in 1969 from UW Superior and his MA in 1983 from the UW-Madison. Mr. White has taught math at the high school and college levels and currently teaches mathematics and art at the Courte Ojibwe College. He also held an administrator role for the tribal K-12 program on the Courte Ojibwe Reservation for over a dozen years. In 2009, Mr. White was chosen as one of 3 Indigenous Artists of the Year by the National Museum of the American Indian in Washington, D.C. He was also selected as the Indian Teacher of the Year by the Wisconsin Indian Education Association, and he was selected as the Outstanding Alumni of the Year by UW Superior. Professor White, please lead us in your blessing, with your blessing.
Akawedash tabo majitayan at the gopangi wakaduyan, indicito osa mezananaquet indigenikas, miomash koniganing, udawasa gaiganing, njibayan, tebishkun, nitisimug, mewinjago, indicito pangisa and the bajitun, pangisa, shaganashimoan, tabwa majayang, osa, ojibwe moyang. I wanted to introduce myself just before I say my prayer. My name is Mason Anaquet, a name given to me by my mother many years ago. Mason Anaquet literally means that clouds spread out on the sky in a certain way, in a certain color. And my mother, in her eloquence of Ojibwe in English, said that means fancy sky. So she gave me the name Mason Anaquet, and her interpretation was it means fancy sky. So, and I'm, even though I often give prayers nowadays, I did not learn my language as a young boy assigned by parents who spoke Ojibwe to each other, as happens with many of our people now. I understand that they learn English as their first language. And so we are trying to teach our language to our students here, and I'm teaching a couple new courses I haven't taught for a while. Our Ojibwe 2 and 4. We have 4 courses in Ojibwe we teach at our community college. So I'm going to be teaching a couple courses next term. And I look forward to it, even though I haven't done it for a while. I wanted to stress the importance of our language and our culture ways and in our very our health. If we can't consider as part of how healthy we are, or to be healthy, a spiritual component. We need to look at the spiritual component of what we are doing in order to be truly healthy. So I'm happy that I can contribute in this way to the health of our people, not only on our reservation here, but to a wider community, that we have to consider our spiritual health as well as our eating good foods and being kind to each other and all the other components of being healthy. So with those just a few preliminary words, I'll start now. The tum dashin gagweji magwawasa, the ganazet money do, udapanama shin rawasema. Nevi pagidinaman rawasema ishkwa, ijitige yang wa oasa, idashigo when he says you way bakumanugum. Minawa dashigo ni winandumanani, pangisa ni mishomisanani, you dash bimigijigum, kiman gochigo ma, Anishinaabe king. Ambesano, being in the Mishinama o Wajitike Yangomanungum. Minawada Shigo, Niwi Nandamananik, Pangisa, Nimishum, Sananik, Givita, Gijik, Asian number, Tabiwad, Nimishum, Sanan, Winsa, Goewa de Wabanung, Winjipawa, Gwenungo, Winawa, Winabujo, Misko, Gijik, Gaye, Ambesano, being in the Mishinama o Wajitike Yangomanungum. Bidashigo, when he says you way back Omanungum. Shawainim Kinagoa Gaye, Kapiajawadumanungum, Minawada Shigo, Kinagoa Gaye, Kinawa not Mahaganug, Biziwayama Nishinabe, a king. Minawada Shigo in the Kito, Sanimi Shomisananik, Abitamegama Shawanung, Abesano, Binin the Mishinama o Wajichige Yangumanungum. Bidashigo Minusemaguk, Akanago, Wajichige Yanguma. Shawainim Gosha and then away Maganak. Minawasa go kino kikino maganug kinago gaini janasi nanik chinishinabe gaye idashigo gagwe jamagni mishomisanan nimishomisanani kiabitamegima imasa ninga bianung binamaushana oasa binwani madnungum oasa nimbago sainamin gasi tu keg ginudin ninwa idashigo when he says you way bakumanugum. When he saw Kinagoa guy, in Bibunishiang, Minawasa go Webinishiwad, Kinagoa guy, Chinishinabeg. Minawada Shigo and Kagwechi Magawasa, Winsa go Nimish Homus and Anik, Yabitamagi Wadenung. Awasa Basic Nimi Shomus Kanabajigo Eziki Kindamin, Awasa Gabi Bunukade. Awasa Gabi Bunukedo, Tapanama Shinamanu, Wakiduyan Minawasa go. Wapinda kuchike yangoma. Owasanim bago sainamin, Webinishiwad, Kinagoa gaye, Chinishinabeg, Abenoja gaye, Kinagoa gaye, Kikino Magna, Kinagoa gaye, Nijanishinabeg, Anukiwad, Mago Chigoa ma, Nishinabe akin. Minawada Shigo, Pega Shigo, Sa, Nimishomas, Anan, Jeshuena Mishinam, Nimishomas. We do Kawashinama, O Wajicige Yangoma. Bidashigo Wabinda Shinama Osa, Ejimino Dudadi Yang o Osa Tibishko Ejichige Yangomana, Nungum, Minuasago and the Kito Sa, Nimishomas, Anan, Ajashuena Mishinam, Nimishomas, Ajashuena Mishinam, Gije Manidu, Minua in the Kito Sa, Nimishomas, Ajashuena Nimishinam. Misa Yumanekwa Keduyan at the Gopangiwa Keduyan. I want to give you a brief translation of some of the words I use in the prayer this afternoon. I called upon the manifestation of the Creator that exists all around us. Some people, when they say their prayers, they use a pipe or some kind of maybe offering of tobacco and offer it to the sky and the ground and all the 4 directions, and that's what I offer my word today too. From the east, I ask for the spirits of the east to bring us a good day today. From the south, I ask for gentle winds, not just only to caress our face and our hands, but to caress our very spirit, so that we can be kind to each other and live in a good way. From the west, I ask the creators to make the spirits of the west to make small their winds. To make small their winds, so that we can survive another winter. We can survive another well in a good way. From the north, we in our cultural traditions, we call one of the spirits of the north the winter maker. The winter maker arrived early this year and is treating us kindly, and we ask that the winter maker can help us to get through this winter. Long ago, when I was a young man of 25 or so, my mother had me give a ceremony of naming 25 children in the school that she was elder at. And, that long ago, and that's nearly 50 years ago now. My mother was asked to name all the children in an immersion school, Ojibwe immersion school she worked with. It was a Montessori school, so that was like a kind of advanced thoughts for that time in the early 70s, and she had advanced thoughts her whole life to give all these kids Indian names. Some had Indian names, spirit names themselves already, but she knew that they all needed to have an Indian name. So she gave me a word that I use almost all the time in my prayers, and it's Webenishiwad. I try to use that in my prayers to this very day. Webenishiwad means that they can survive the winter. In her time when she was a young lady, and my parents were young parents in the 1920s, they had hard times. My parents had 13 children in their life. And when I was a young person, I only knew that there were 10 of us. So I didn't know for a long time that 3 of my brothers and sisters, 2 sisters and 1 brother, had passed away before I was even born. So in the 1920s and 30s, such things happened to our people. There was a high infant mortality rate. Diseases like whooping cough and pneumonia took our children away from us way too early. So when she gave me the word Webenishiwad to use in my first prayer, I still use that word because it means we can survive the winter. We tell our ages in Ojibwe by how many winters we survive. When we have our most strongest ceremonies there in the spring after the winter goes. So that if we can survive another winter in our lives, then we know that we've been blessed by the Spirit, by the Great Spirit, to have another year of life. And I'm happy when the snow comes. I'm sad when it goes somehow, but I'm happy too when the snow does leave and we can start our year in a good way. So I use the word Webenishiwad, a word my mother gave me, and I wanted to share a few words with you today. And I hope I'm not taking too long or taking too much away from your efforts here today. I appreciate being given the chance to be here today. I often say prayers around our community. I'm looking forward to naming several young babies when the snow goes away this year, and we start our school semester off with a prayer. We'll start off our school year with a ceremony next week, and so we often pray at the start of our ceremonies and even our meetings. We do that, and so we often give thanks and recognition to the Creator and all the manifestations of the Creator. We often name so many different spirits, but they're all manifestations of the Great Spirit. So those are the words I wanted to share with you, and thank you for listening to me. Appreciate the opportunity to be here. Thank you.
Thank you very much, Professor White, for sharing that blessing with us, and also sharing a little bit of your family story and part of you with our community. We really appreciate it. It was a beautiful blessing.
Thank you.
So we are going to go ahead and get started. Maggie, do we have an agenda?
Yes, so let me go ahead and pull that back up. for all to see.
So while she's doing that, I just wanted to give you a little bit of background. This is the National Native Health Research Training Webinar Series. It was born out of, it came to fruition after we had to cancel our yearly research conference that we've been hosting over the last few years. And the research conference in general has a really long history through a partnership and with the Native Research Network, the Indian Health Service, and the American Indian Health Education Consortium, or AHEC. I'd like to just say a big thank you to our partners, AHEC and NRN, for helping us all these years and for joining our efforts and being able to provide the research conference, but also this webinar series. So after we had to cancel the research conference due to the pandemic, we came up with this series of webinars, and we started hosting those in June, and we've had one every month, June, July, August, September, October, November, December. And this is going to be our last webinar for the near future. But welcome everyone. We are going to go ahead and get started. Let's see if we can go to the next slide. Our first presenter is Dr. Andria Apostolou. She is, hold on, let me pull this up here. She'll be presenting on the National Sexually Transmitted Infections Strategic Action Plan and STI Epidemiology among American Indians and Alaska Native communities. Dr. Apostolou, since 2014, Dr. Apostolou has served as the Indian Health Service National STD Program Lead. She is also a senior epidemiologist with the Division of Epidemiology and Disease Prevention, working on a variety of public health projects, including immunizations and currently on COVID-19 response. Dr. Apostolou was previously with the Centers for Disease Control and Prevention as a health systems and integration scholar and as an epidemic intelligence service officer assigned to the New Jersey Department of Health. She holds a PhD in molecular medicine from the University of Maryland and an MPH in biostatistics and epidemiology from the Johns Hopkins School of Public Health. If we can please welcome Dr. Apostolou. And Dr. Apostolou, you can go ahead and get started.
Thank you so much, Rachel. And thank you for the invitation to speak on today's meeting. Thank you to both Rachel and Maggie for all their support. Go ahead and share my screen. Let me know if you're able to see it.
Yes, that's perfect. Thank you.
Great. So for today's presentation, I will be sharing with you some background on STIs, and you'll hear me speaking about STIs, sexually transmitted infections, and also sexually transmitted diseases. So I will use that term interchangeably. And then I will give you an overview of the Indian Health Service National STD program and statistics around the epidemiology of STIs among AIN populations. And I will end with some information on the first ever National Strategic STI Plan that was just released a couple of weeks ago by HHS. So each year in the US, it is estimated that 20 million new cases of STIs occur. Chlamydia and gonorrhea are the most commonly reportable conditions, with millions of cases reported each year by local and state health departments. STIs can be asymptomatic, and many health consequences can occur without prompt diagnosis and treatment, including pelvic inflammatory disease, ectopic pregnancy, infertility, and also increased HIV risk. And unfortunately, infants born with congenital syphilis can suffer from health problems, including blindness and deafness, developmental delays, and bone and joint abnormalities. And congenital syphilis can also lead to infant loss. So nationally, for all races, half of all STDs occur in those under 25 years of age. And these statistics vary by disease, but as you see in the infographic at the bottom, young people account for 70% of gonorrhea cases and 63% of chlamydia cases. So over the past decade, we have seen unprecedented increases in STIs. The US had 2.4 million reportable STIs in 2018, with increases the last 5 consecutive years. So from 2014 to 2018, we have seen that syphilis cases increased by 71%, congenital syphilis have increased by 185%, gonorrhea cases have increased by 63%, and chlamydia remained at records high. Nationally, HPV, the human papillomavirus, remains the most common STI, but fortunately for HPV, we now have a vaccine and we've had it for quite some time. So we have a really good tool to use against HPV, but unfortunately, that's not the case for other STIs at the moment. So STIs affect groups across the population. Many of the most vulnerable members of the society, though, do bear the brunt of their impact. So the spread of STDs is directly affected by social, economic, and behavioral factors. American Indian, Alaska Native populations bear a disproportionate burden of STDs, with chlamydia and gonorrhea rates among AIN reported to be about 4 times those of whites. And then syphilis and HIV also have disproportionately higher impact among AINs. Before I present to you some data on STI epidemiology among AIN, I just wanted to spend a little bit of time to introduce the IHS STD program. So we sit at, we're housed under the IHS headquarters, under the Office of Public Health Support and the Division of Epidemiology and Disease Prevention. We are thus located outside Washington, D.C. in Rockville, Maryland. And I have the website link on the bottom of this slide if you wanted to take a look at our website. The IHS National STD Program goals include raising awareness of STDs as a high priority issue among AIN communities, building partnerships both internally within IHS and externally with federal, tribal, local, and state public health officials, and supporting surveillance activities to characterize the epidemiology of STDs among AIN communities and to guide recommendations for interventions. Whenever possible, we also try to offer assistance during outbreak response efforts, and we also provide trainings for medical providers and public health professionals. The Indian Health Service and CDC have a strong collaboration going back to 2006 to create AIN-specific reports. In 2018, we created a long comprehensive report of STD statistics between 2011 and 2015. And the focus of my presentation today will be on an updated report that our team has completed using 2013 to 2017 data. And we're hoping to release a similar report with more updated information from 2015 to 2019 timeframe when CDC finalizes their national STD surveillance report. Which hopefully will be sometime in early spring. There was a delay this year due to the pandemic. So the report I will share with you today presents statistics and trends for chlamydia, gonorrhea, and primary and secondary syphilis among AIN between 2013 and 2017. It has 2 main components. The first piece has the national STD profile, which provides an overview nationally of STDs and among AIN in the US. And then the second part presents rates and trends for the 12 IHS administrative areas for the counties where IHS provides services. The STD case data were obtained from CDC's National Identifiable Disease Surveillance System, which receives reports from the 50 states and Washington, D.C. I will now present to you the data on chlamydia, gonorrhea, and syphilis. So first for chlamydia. So from 2013 to 2017, rates of reported chlamydia cases increased among AIN, similar to all racial and Hispanic ethnicity groups. So you'll see the second line from the top, AINs have consistently had the second highest rate of chlamydia among all other races and ethnicities for the entire time period. And chlamydia rates among AIN were higher than the US total rate for the entire period. They initially decreased between 2013 and 2015, just slightly, and then went back increasing from 2015 to 2017. This pattern is very similar between AIN males and females, with females having higher rates than males. And you'll see on the right side of your screen, females, again, have higher rates, but the most impacted age group are the 15 to 24-year-olds. So shifting now to gonorrhea, nationally, gonorrhea rates increased slightly between 2013 and 2014, and we're seeing a higher increase between 2014 and 2017. Again, here for during this time period, for all 5 years, the gonorrhea rate increased among all race and ethnicity groups. And for AIN, this increase was 95%, with AIN having consistently, again, the second highest rate among all racial and ethnic groups. Starting in 2015, you'll see a little bit of the slope changes. So we're seeing an even steepest increase in rates of gonorrhea among AIN. And similar to chlamydia, AIN gonorrhea rates were higher than the US total rate for the entire period. Gonorrhea rates have been increasing steadily since 2011, and they have almost doubled among AIN between 2013 to 2017. These patterns, again, very similar among males and females, with AIN females having higher rates than males. Nationally, among all races and ethnicities, males tend to have higher rates than females. But so this is a little bit unique for the AIN population, although we're starting to see a shift in some of the IHS areas having higher rates among males than females. So in terms of age distribution, AIN females between 20 and 29 are mostly impacted. So it shifts slightly older than chlamydia that I showed you earlier with the 15 to 24-year age groups impacted. So a little bit older females impacted for gonorrhea. So for syphilis, from during 2013 to 2017, the rate has increased among all race, Hispanic ethnicity groups. And the greatest increase among all ethnic and racial groups during 2016 to 2017 were unfortunately observed among AIN communities, with a 39% increase. And this was partly due to a few outbreaks. When looking at rates by race and ethnicity, we see that AIN rates were the 4th highest in 2017. Syphilis rates, again, for AIN were higher than the US total in 2017. After initially declining between 2014 and 2015, the syphilis rates increased dramatically between 2015 and 2017, with, unfortunately, as I said, several outbreaks contributing to this sharp increase. And overall rates have more than doubled between 2013 and 2017. Unlike chlamydia and gonorrhea, primary and secondary syphilis affects mostly AIN men. The trend pattern is very similar among AIN males and females. And even though men have higher rates compared to other ethnic and racial groups, AIN women still have the second highest rate, almost 3 times more than white women. So there's a disparity there among AIN females as well. For age group distribution, we do not see a particular pattern, with unfortunately almost all age groups affected with syphilis. Perhaps AIN males between 20 to 34 are mostly impacted. We do see cases among many different age groups. And although I am not presenting here data on congenital syphilis, unfortunately, we are also seeing a rapid increase in congenital syphilis cases among AIN. And that could be, contributed from the rise in syphilis cases among women of reproductive age. So as I mentioned, the report has actually IHS national and individual IHS area profiles. In the interest of time for today, I just wanted to show you 3 graphs that we have included in the report. So this is a ranking for each of the IHS areas. So for chlamydia, the area with the highest rate was Alaska, and the one with the lowest rate was California, and Alaska had the highest number of cases. For gonorrhea, similar pattern, Alaska had the highest rate with the lowest rate in California, and Alaska again had the highest number of cases. For syphilis, a little bit of a different pattern. The highest rate was in Phoenix, and the one with the lowest was in Billings, and Phoenix also had the highest number of cases. And Phoenix area has experienced several outbreaks actually starting around 2017. So to summarize the results of the report, there's a nationwide continuing increase trend in STDs. Our findings highlight disparities among AIN, with national data indicating that in 2017, AIN had the second highest rates for chlamydia and gonorrhea, and the fourth highest rates for syphilis among all racial and ethnic groups. And regional differences for each of these conditions were observed, highlighting the importance of continuing monitoring trends at both a national and local level to determine impacted populations and to better design interventions. AIN youth and AIN women, particularly women of reproductive age, are mostly impacted by STDs. So just wanted to share some of our most recent initiatives at the National STD Program at IHS to address these statistics and these trends. We recently, about a year and a half ago, we had started a national AIN STD prevention work group to connect key stakeholders and to provide a forum for discussing public health, clinical community, and other partner perspectives around STD prevention. And as you can imagine, unfortunately, due to the pandemic, we had to take a pause this spring, but we do hope to restart meeting very, very soon. And perhaps one of the topics that we will be discussing is actually the impact of the pandemic on STI services for AIN people. So that perhaps could be one item that we discuss when all the work group members reconvene. And IHS has also participated in the development of the first ever national STI strategic plan. We participated in the planning phases of the strategic plan and will be continuing to work to report progress towards the strategic goals. So what is the STI strategic plan? This plan was developed under the auspices of the HHS Office of Infectious Disease Policy. So I have provided here the link where you can find the entire report. It's a lengthy report, but it's pretty comprehensive. And this is the same office at HHS that oversees the development of the strategic plans for HIV, viral hepatitis, and the vaccine action plan. So definitely we focused a lot on this endemic across the national strategic plans. The STI strategic plan, as I said, it's the first time that the nation has a strategic plan to follow. It's a 5-year plan from 2021 to 2025, and with annual targets through 10 years. So 2030 is our end of the target period. And this was developed by a federal steering committee, which included 5 federal departments and 15 HHS offices, including IHS. And we met monthly from April 2019 to January 2020. There were several opportunities for public comment at the initial development stage and at the final stage. And there were at least 2 listening sessions conducted in Indian country. So the committee again took an integrated approach to prevention, screening, and linkage to care among all components of this endemic, and alignment across STI, HIV, viral hepatitis, and national strategic plans. So in this slide, you'll see the vision of the plan, that the US will be where a place where STIs are prevented and where every person has high quality STI prevention care and treatment while living free from stigma and discrimination. The vision includes all people, regardless of sex, age, gender identity, sexual orientation, race, ethnicity, religion, disability, geographic location, or socioeconomic circumstance. The plan has 5 goals focusing on prevention, improving the health of people by reducing adverse outcomes of STIs, accelerating progress in research and innovation, and reducing health disparities, and achieving a coordinated and integrated effort to address STIs. So most goals and objectives and strategies in the plan are not infection specific and apply to all STIs. However, there's a focus on the 4 STIs that have the highest incidence and impact on the health of the nation. So chlamydia, gonorrhea, syphilis, and HPV. So priority populations and indicators are based on CDC data, and national incidence, prevalence, and morbidity rates indicate that adolescents and young adults, MSM, and pregnant people are mostly impacted by the 4 STIs in the STI plan. And within each of these populations, certain racial and ethnic minorities, including AIN and certain regions, are further disproportionately impacted by these STIs. So identifying priority populations helps focus our limited resources to have the greatest impact on reducing disparities and improving health. So again, due to limited time, I just wanted to show you one of the goals and strategies. So this goal aims to address health disparities, and it aims to reduce stigma and discrimination associated with STIs. And to one of the strategies to train providers to deliver high quality, culturally and linguistically appropriate, non-discriminatory, non-judgmental, compassionate, and comprehensive sexual health services, and to also address social determinants of health. So how we will measure progress, just really quickly, just to show you that the plan has indicators. And so there are 7 core indicators, and some of the core indicators are also stratified by one or more of the priority populations for their subgroups. So the progress can be measured towards reducing disparities as well. So this establishes 7 disparity indicators. And for each indicator, the STI plan records baseline measurements and establishes annual targets through 2030. So the STI plan recommends, in addition, developmental indicators to help us build surveillance systems and to collect data in domains where data is currently not collected. So just to show you an example, for the disparity indicators, it calls out to address congenital syphilis rates among AIN communities. So this is very relevant to our communities. So what's next for the plan? So in 2021, on the federal side, we will be creating an implementation plan that will include also annual reporting, and other stakeholders are encouraged to also focus on activities that resonate the most with the needs of the populations they serve and the services they provide. The goal nationally is to create a whole of a nation approach with federal, state, local, and community participation. So just wanted to end there and acknowledge the co-authors of the CDC, IHS, STI surveillance report, and also special thank you to Carol Jimenez from OIDP, who kindly shared some of the action plan slide deck with me. And here's my contact information and the website of the National STD program and our listserv. If you wanted to join the listserv, you just click the link and just provide your name and email address, and you'll receive information from us on training opportunities and other events. So happy to answer any questions, and thank you so much for inviting me again to present today.
Thank you, Dr. Apostolou. That was a very informative presentation. Let's see if we have a couple of questions here. I think I saw Timothy ask a question. Can you see the questions, Maggie?
Yes. So there's one from Timothy Thomas. He asks, is there an understanding or explanation why Alaska would have high rates of gonorrhea and chlamydia, but low rates of syphilis? HIV rates were not presented, but those are also low in Alaska.
Yeah, our program focuses mostly on chlamydia, gonorrhea, and syphilis. IHS has an HIV program that targets HIV infections. We do partner a lot, but yes, I chose not to show today, just also because of limited time, the HIV data. That's a great question. Most of the rates among gonorrhea and chlamydia are among females, so that's probably where the disparity is in Alaska. Most of the cases are among females. Syphilis and HIV rates are mostly among MSM populations. So I'm not really sure why the rates are low in Alaska, but it's definitely a different epidemic with mostly women impacted.
Great, thank you.
I have a question, Andrea. So
Sure.
You had mentioned the pandemic, and how do you all think the rates will be affected during the pandemic? Do you think they'll have go up or down, increase or decrease?
That's the $1,000,000 question. We don't know, actually. Well, I think only time will tell. I think in the initial and I don't know even now, like I know a lot of people are actually like avoiding seeking care. So that could have impacted, screening and unfortunately treatment of STIs. So I think we could have seen a dip because people just didn't seek care and didn't get their routine screenings. But on the flip side, unfortunately, if we are seeing, if people were infected and didn't seek treatment, then unfortunately we're going to see persistent STI. So that's again the million-dollar question. We've been in discussions with CDC. I think only time will show. The other component to this is that unfortunately, the public health infrastructure has also been focusing more on the pandemic. So there's not as many resources put into contact tracing for STIs because everyone is doing contact tracing for COVID-19. So I think will be impacted not just in the number of cases, but perhaps in the quality of the data that we will get for 2020 and maybe 2021 as well.
Okay. Thank you, Andrea. Do we have time for one more question, Maggie?
Sure.
So question came in, how can tribal colleges and other colleges help in the national effort to reduce STD rates among AIANs? And is there an information campaign?
That's a great question. As you saw in my presentation, unfortunately, youth is mostly impacted by STIs. So definitely bringing awareness to the population that attends the tribal colleges would be one component. I'm not aware of a current campaign. Again, the plan was just released in the last 2 weeks of 2020. So that definitely is going to be part of the implementation plan and kind of sharing information. I'm not really sure whether tribal colleges have health clinics. So that's another component. If there are health clinics at tribal colleges, perhaps incorporating sexual services and reproductive health as part of your health clinic initiatives could be one component to provide a more comprehensive health services to the population that attends the tribal colleges.
Okay, thank you. Thank you, Andrea. I think that's all we have for questions.
Thank you so much.
Thank you, Andrea, for joining us. We really appreciate your presentation and participation in the webinar.
And then real quick, before we move on to our next presenter, I'm going to pull up our evaluation on the screen. So I have just launched that. So if you could just take 30 seconds to complete that, that would be very helpful to us. And as a reminder, if you're on your cell phone, we will make sure to post this evaluation on our website. So if you wanted to complete it at that point, you are welcome to. Looks like about half of you have responded, so we'll give it maybe another 20 more seconds. Okay. And that is it. So thank you all so much, and we will move right along.
Okay, so we'll go ahead and get started with our next presenter. And let's see here. We have Dr. Sheila Caldwell. She is coming to us from the National Institutes of Health NARCH program. Dr. Caldwell is a program director in the Division of Research Capacity Building within the National Institute of General Medical Sciences. Dr. Caldwell manages IDEA networks of biomedical research, or NBRE, and Centers of Biomedical Research Excellence, which is COBRE grants. In addition, she directs the Trans-NIH Native Research Centers for Health, which is NARCH. Dr. Caldwell earned a PhD in molecular and cellular oncology from George Washington University. Dr. Caldwell conducted postdoctoral research at the National National Cancer Institute, I think is what that's supposed to say. Welcome, Sheila, and thank you for joining us. We're looking forward to hearing all about NARCH.
Good afternoon, everybody. So I'm going to switch gears. This is not necessarily, so this is not a disease-focused talk, but rather a program-focused talk. As mentioned, I oversee the Trans-NIH Native American Research Centers for Health program. Next slide. Thank you. There we go. So the NARCH program has actually positioned itself into in the National Institutes of General Medical Sciences. Our mission runs the gamut. It supports basic research and research in specific clinical areas that affect multiple organ systems. It's also one of the leaders at NIH for providing leadership for training of the next generation of scientists. As well, it is focused on developing and increasing workforce diversity. And lastly, where the NARCH program actually sits is a division that focuses on capacity building and research infrastructure and networking. Next slide. Thank you. So just briefly, this is NIGMS with all its different divisions. The NARCH program is located in the Division for Research Capacity Building, but we do work alongside the Training, Workforce Development and Diversity Division as well. Next slide, thank you. Within our Division for Research Capacity Building, we actually have several programs. As mentioned, was the Institutional Developmental Awards, the IDEA program. There's a few mechanisms under this. That is actually a congressionally mandated program. The program is geared toward reaching states that typically do not get a lot of funding from NIH. They're similar to EPSCoR. The number of states are similar to EPSCoR. There are some differences. Additionally, there are some differences with the program where the IDEA program, the grants are submitted by institutions and they decide what grants will actually be submitted. We also have, as mentioned, and what I'll talk about today is the NARCH program, the Native American Research Centers for Health program. Additionally, we have support of the competitive research, the SCORE program, which does go to universities that have had a historical background of supporting or serving underrepresented minorities in science, or underrepresented minorities, I should say. And then finally, we have the Science Education Partnership Award program, the SEPA program. That is actually a K through 12 program that focuses on STEM and providing STEM opportunities and knowledge to hopefully underrepresented groups in rural areas. It's a great program and definitely one hopefully some folks will look into. Next slide. So a little bit of background on the Native American Research Centers for Health program, or NARCH. It's, as I had mentioned, it's a trans-NIH program. On average, there's about 15 NIH institutes and centers, as well as NIH offices under the director that will sign on. I have listed a few here. The ones underlined are the ones that are currently signed on to the NARCH funding opportunity announcement that is active. And again, under the NIH Office of the Director, there are actual several offices, such as the Office of Research for Women's Health. It is not its own institute, so it falls under OD, and they are supportive of the NARCH program. It's a partnership with between NIH and Indian Health Services, and its goal is supporting research capacity building in American Indian and Alaskan Native communities to address the health issues that are pertinent to those communities, those AIAN populations, and providing research experiences and training for faculty and the students. Next slide. So again, a little bit of background. It was actually a program that was established back in 2001 after a meeting brought together some AIAN communities and researchers and expressing what some of the concerns with research were and how NIH may be able to assist in in helping these communities, along with IHS. So what's unique about the program is that with the NARCH grants, the grant applications that come in do not have to be disease focused. Rather, they can actually have several different disease areas within their grant application. This allows the different NIH institutes and centers and offices to support individual projects within a grant. And so co-fund with NIGMS these actual grant applications or grant centers. And so it allows us to get more support across NIH by doing this. Since the start of the program, overall 73 NARCH grants have actually been supported. And that actually, you know, oftentimes we'll see 3, 4, 5 projects within a NARCH. So that's quite a few projects if you add them up. In 2012, we actually added in the research capacity building component. I had come over to NIGMS, was working with Cliff Poudry, and I had come from the IDEA program where we're very much focused on the on capacity building and infrastructure building, because we want to allow that research to be sustainable within the AIAN communities. So we added that component in to allow those NARCH communities to think about capacity building within their own communities. In 2012, the program management of the NARCH moved over to NIGMS. Previously, it had been with IHS. That was not because IHS wasn't doing a good job. It was actually because Congress changed a lot of laws and rules. And that was, they were working toward reducing overlap between different agencies under DHHS. And so some rules changed, and we had to take a different approach, and this was the best solution at the time. But we continue to work with IHS on the program and helping us with the different communities. The funding opportunity announcement runs for 2 consecutive years and then is actually quiescent for 2 years. It allows the different institutes to roll funding to new grants that come in because the grants themselves are 4 years. Next slide. So I just wanted to give a brief overview of some of the FY 2020 NARCH support from the different institutes. As you'll see, there's quite a few institutes listed. NIGMS does support a bulk of this. Reason being is because, one, we support the training in training programs as well as capacity building, but as soon as any of the different institutes agree to fund a project, we agree to fund the administrative core. So we fund all the administrative cores as well. So different institutes will participate at different levels. As you can see, NIAAA has supported, provided $500,000 for grants currently ongoing, and NIDA at $1.15 million for various programs, projects, I should say, within the NARCH. Next slide. So the current NARCH funding opportunity announcement, as I had mentioned, PAR 2125, is active. We had a application submission date this past summer in July. I believe it was July. It might have been moved to August. We moved the date a bit because of the pandemic to give folks a little bit of extra time to submit. Those applications were received and were reviewed in October, November, and those applications will actually go to our upcoming councils. NIGMS's council is the beginning of February, and other institutes and centers will also bring the projects that they're considering to fund to their councils as well. And we hope to start to have funding decisions by spring at some point in supporting those different projects. But the overall goals for NARCH are really about, again, supporting the health research projects that are prioritized by the tribal communities. We also want to support student development, or I should say also scientists and health professionals in that are working within the community, as well as those that are from within the communities that are focused on the AI and health research needs. Again, as I had mentioned, it's really a important factor to support the research capacity for the targeting health research needs within the AIAN populations to, again, allow that sustainability. And again, we also want to be able to support collaborations between the federally recognized AIAN tribal entities and research intensive institutions to allow partnering so that different resources, rather being duplicative, can be supported across different institutions. Next slide. So what again is unique with the NARCH application is that it must be awarded to a federally recognized tribe or a tribal organization, a tribal entity. A research intensive university cannot apply for a NARCH application. The reason for allowing the applicant to be the federally recognized tribe or tribal organization was that we then allow the AIAN community to control the research that's being conducted, to prioritize the research that is being conducted within their communities, and to decide, what that should look like. The annual budget cannot exceed 1 million in direct costs, and at least 30% of that budget must remain within those eligible AIAN applicant organizations. The reason for this is because, again, we do not want a research intensive institution utilizing or using a tribal entity to support research they're interested in and not the tribal community. The applicant is the tribe, and they're controlling the budgets as well, and that's really important. As I had mentioned, the awards are made for 4 years. And also, as I mentioned, the funding opportunity is still active. The next receipt date is June 24th, 2021. Next slide, please. So what does the NARCH application look like? We really wanted to make it as flexible as possible, hence the reason we use the SO6 mechanism rather than a center grant mechanism, which is usually a P grant mechanism. And because, again, we wanted to accommodate what the tribal communities wanted and what they wanted it to look like. So within the application, there is an administrative core that is required. The administrative core really is helping the different proposed projects and components work together, as well as general oversight. And really the goal is for the administrative core to be within the tribal community. That may not happen initially if they're partnered with a research institution and the research institution has a larger bandwidth to oversee some of the administrative functions. We certainly understand that, but the goal really is to train those tribal communities to be able to take over their own administrative cores so that in the future, again, we're building capacity. We're allowing for that infrastructure to happen so that more research can happen, that those functions within the tribal community for the administrative core can then start thinking about reaching out and garnering more support for research in whatever way that is, if that's from SAMHSA or if it's continued to be through NIH, for example. The other components, you need to have at least one of these, but you can have any combination of the below components, which are either a student career enhancement project, a faculty career enhancement project, a capacity building project, or a research project. And within the research project, that also includes pilot projects. Pilot research projects are smaller and do have a budget limit in comparison to a research project, which is much, can be much larger and can actually be a clinical trial if proposed. So again, as I had mentioned, what also is unique about an SO6 is there is no scientific theme required as there are with center grants. Rather, the overall overarching goal of the application is actually to focus on the health research needs and the requests of the AIAN community. So it is what they want to see. They want to see a diabetes project and they want to see a cancer project. They can put that in that same application. Next slide, please. So I wanted to give you just a quick slide. It's quite a lot on there, but these are actually the current active NARCH awards and where they're located. So you see there's a range between tribal colleges, for example, Dene College is on here. Also, there are tribes and tribal health boards as well. So for example, the White Mountain Apache tribe has a NARCH. Actually, they have 2 NARCHs, and they have chosen to partner with Johns Hopkins as their research institution. You don't necessarily need to be partnered up with the research institution, but they have chosen to do that. As well, there's the Northwest Portland Area Indian Health Board as well. Another example of an Indian Health Board. They are representative of many different tribes actually. And so those different tribes can be part of the different NARCHs that are proposed. We also, for example, we have South Central Foundation, and they actually have their own hospital and can run clinical trials through their NARCH application. And so I just wanted to give you a sense of the different types of NARCH grants that are awarded, where they're at. They are, next slide, please. I have a coworker that loves to do maps, so I let her do a map, and so you get a sense of where they are across the United States. We have had grants in the East Coast areas as well. They've simply expired, so hopefully they'll come back in. But for example, the National Congress of American Indians, or NCAI, is located in DC, and they did have a NARCH, as well as AHEC also had a NARCH, and they're located out of Virginia, and USET also had a NARCH, and that was located out of Tennessee. So we have had them on the East Coast as well, but just currently they don't have awards. Next slide, please. So in addition to the different places that these grants are, I wanted to also give you a sense of the different types of projects that come in. And these are not the only projects within the particular grant award, but I just wanted to give you a sense of how much they range, or the diversity within the proposed project. So, we have a student enhancement project at Dene College, and that actually works with master's students, Masters of Public Health. And they're actually getting hands-on experience right now with the coronavirus research and doing a project. So that's pretty amazing. We also have, research projects, for example, the cigarette smoking among American Indian women experiencing intimate partner violence. That one is taking place at Black Hills Center for American Indian Health. Or also another project, developing and evaluating a culturally grounded mother-daughter intervention to promote protective factors and reduce early substance use among Apache girls. And that one is at White Mountain Apache Tribe. But again, they really run the gamut as to what they want, what the tribal communities want, and what that looks like, and what they want to put forth. And again, there are many different institutes that participate, so the ability to support these different projects is there within the NIH in the institutes and centers, so that's great. Next slide, please. Sorry, there's actually more examples. Sorry, I forgot I had done a second page. So again, it's just to give you a sense. Some are focused on student and faculty development. The Northwest Portland Area Indian Health Board has actually been running this project, I think from the beginning, from 2001, actually, the Improving Health Research Skills for AIAN Students and Fellows. Quite a successful program, actually, that has run over the years. But again, it really is to give you a sense of the variance among the proposed projects. For example, the Tribal Equine Assistant Psychotherapy, Building Youth Resilience Through Horses, through the Albuquerque Indian Health Board. So what is key in looking at or thinking about submitting an application, again, is looking at the funding opportunity announcement, looking at the current institutes that are supporting or that are listed on that funding opportunity announcement to know what types of projects would be acceptable in being submitted. You know, if there's an institute that's not named on there, then obviously you don't want to submit a project that's within that area, because then that institute isn't present to support it. Next slide, please. So I just wanted to give just real brief, there's just a couple of slides here to show, you know, that it's wonderful with the success of some of the projects that have occurred in being able to actually not only produce peer-reviewed manuscripts, which is great, but also community, you know, education, as well as community impact. So for example, this is the Oklahoma NARCH, and Dr. Judith James had a project looking at rheumatic disease among the Oklahoma tribal populations. And what was significant is, one, that there is significant morbidity within the AIA and community in their Oklahoma population. But they noticed that there were actual differences in the associated autoantibodies that are typically tested for, which were established off of a white population. And they noticed that there were differences for their Oklahoma tribal communities. And they were able to look at those and identify that the autoantibodies that were associated with those Oklahoma populations, realizing they were different. Not only was this impactful, they were actually able to make a difference in their clinics to then switch over and impact how or which biomarkers were actually looked at in the tribal communities, because they were different. So again, having an impact within that community. Next slide, please. And then I just wanted to quickly highlight the Albuquerque Area Indian Health Board, one of their prior projects. This was a student-focused project, and looking, and what they did was actually, and they actually still have a project, supporting research internships for American Indian, to allow them to, you know, put them in research internships to develop those behavioral and health research skills. And they were able to provide tuition scholarships to 33 AIA and graduate level students, and saw 18 students. This, I should say, is about a year old, so they probably have an update that I haven't gotten yet. Even more students through graduation in health science degrees. Next slide, please. So I wanted to try to go brief so that I could at least leave time for questions in regards to this program.
Thank you, Dr. Caldwell. That was a very, very informative presentation. Let's see if we have any questions in the chat box. I don't see any questions. If anyone has any questions they'd like to ask through video, feel free to unmute yourself. So
this is Carrie Billy with AHEC, and I had a question. I was wondering, I know you gave some examples of some highlighted projects, but I'm wondering, like, what do you think the key elements are of a strong partnership between a tribe or a tribal college and a Research One institution? And just also, should the research partner institution be a Research One institution?
It doesn't have to be a Research One institution, and you know, it's not even required that they have a partnership, that you have a partnership with a research intensive institution. When we have seen them, I think oftentimes I've seen a lot of different ones. I've seen some that I am not a big fan of, I'll be honest. And I've seen some that I am a big fan of. And those are usually ones where there really is equal support, so that the research intensive university is very understanding and respectful of what the tribal organization is bringing to the table, and really wants their input and wants to work with them on that. And at the same time, the tribal entity understands what they are gaining from the research intensive institution. What I think makes it successful is that codependence doesn't get lazy, that there's an understanding that because a research intensive institution may be taking care of parts of the functions, that there's an understanding that it is their responsibility to mentor that tribe and understanding the roles that they're doing at their research intensive, institution, and being able to try to provide that research infrastructure to be built in for future use within the tribal community. And also understanding for the research intensive side that hopefully there can be future research projects put together, whether it be through NARCH or not through NARCH, whether it be a direct application to either NIH or one of its sister agencies, in a partner manner to support a different type of project. I think sometimes we see relationships that are long established or even short established, but that have gotten very comfortable with each other in its roles, and not necessarily remembering to mentor one side or the other. Because I also think it's the tribe's responsibility to mentor those research intensive institutions and understanding the benefits of the tribe and the nuances that come with tribal research, and being able to understand or being able to stand and saying, these are the things we really truly want, and this is what it will look like. I think that's part of the advantage of NARCH, because the tribal community controls the money. So they can look at those institutions and say, this is what we want, and we control the money. So we would like you to listen to us very carefully, and this is how we want it to look. We went out before pandemic hit and had a lot of conversations with different tribal communities where we could, and talk to them about the ability for them to think about that capacity building and really taking advantage in the perspective of maybe they want to develop their own tribal IRB. I apologize, that is my dog. So maybe they want to think about building their own tribal IRB. And what are those steps? So a capacity building project could be, how do we build our own tribal IRB? That could actually be the proposed project, we told them, and to think about that. And that could be working with an institute, a research intensive institution. How did they develop their IRB? How should our IRB look? In addition, we had, we talked about there are folks out there that do have their own tribal IRBs. Maybe it's even talking about in a grant application, partnering with them to learn how they did it so that you can then take those steps. Or if you've already taken those steps, actually, putting your IRB into place, and what does that look like? And I was really pleased, I have to say that I can't say how many applications we got on this last round, but there were a decent amount of projects proposed focused around tribal communities building their own IRBs, as well as also thinking about databases and biorepositories. And so that was exciting to me, because then that meant to me that tribal community was actually thinking about building that infrastructure within themselves. And that goes again toward future research projects, which we really want to see the tribal communities be able to put forth. So I think there's not one answer to that. I think it's a great question. I don't think there's one answer, but I think that mutual respect is probably very important, and understanding that a relationship that's built now is going to obviously, as most of us know, will develop over time and change and look different. And it's just about us being flexible enough to remember that things do need to change over time, and that's okay. Some things need to stay the same. I mean, if, you know, the research intensive, if, you know, for example, with the Oklahoma where they were doing autoantibodies, if they're, you know, if they happen to have a clinic, but if, for example, somebody else was proposing something similar, you know, they maybe don't need their own PCR core, but the university does have a PCR core. It's certainly reasonable to keep that, you know, core and allow that PCR core to stay at the institution, and maybe not the, you know, the tribal community have its own PCR core. However, again, there's other components that, you know, maybe can be transferred over to the tribal community in building that research capacity.
Thank you, Dr. Caldwell. I just wanted to make a comment, and then we can probably get ready to wrap this up because we're just a little bit over on our time. But thank you again for continuing to partner with IHS. We really appreciate the partnership and the long history that we have together. I think one of the cool things that I like about the NARCH is seeing the students come in as students, and then they go out as researchers, and then they have this long history, you know, with their mentors that started out of a NARCH. We had, I think, 1 or 2 NARCH programs present as part of this webinar series, and it was kind of cool to see those researchers reconnect with their mentors. I think that's a really, really important and positive part of the NARCH is that training component and capacity building.
Yeah.
So
it's like watching your own children grow, right?
Yeah. So Maggie, I think we can go ahead and move on with the eval.
Okay, so I'm going to pull up that evaluation again. And if you can all just take another moment to complete that, and then we'll go back to Rachel for the conclusion of our webinar. So it looks like we have just over half. So we'll give it another 30 seconds here. Okay, last few seconds. Okay, and that's it. Thank you.
Thank you everyone for taking part in the evaluation. And again, thank you for joining this National Native Health Research Training Initiative webinar. We really appreciate you taking the time to listen to our presenters, and I would like to give a big shout out to our presenters for participating. Dr. Andria Apostolou with the Indian Health Service EPI program, and then our division of EPI, and also Dr. Sheila Caldwell from NIH and IGMS. And I'd like to thank our partners, the National Native Research Network and AHEC, for your partnership over all these years. And I think we'll go ahead and wrap up this webinar for today. Thank you, everyone.
Thank you very much.
Have a good afternoon. Hey, Delight. Thank you, and that concludes our webinar.
Thank you.
Thank you.